And this is a slide, obviously, of ventricular tachycardia, the broad complex rhythm with completely dissociated P waves, which you can see in that bottom rhythm strip there. So how do you make the diagnosis of this? Well, the first thing is to do a 12-lead ECG in all patients who collapse and look for suspicious findings. Can you see a sinus bradycardia present already? Is there any sign of AV block, either first degree or second degree? Is there any bundle branch block or axis deviation that would put them at risk of complete heart block? And finally, is there abnormalities of the QT interval that would make them more prone to VT? It can be extremely difficult to specifically diagnose an arrhythmia as the cause of a blackout, because you have to have a recording of that arrhythmia during the actual event. So if people are blacking out very infrequently, you don't know when the next blackout may be, it can be very difficult to capture that on a recording. And often a 24-hour ambulatory ECG will just be too short to pick it up. And you have to use much longer recordings with event recorders or an implantable recorder, which you can leave in for up to 36 months to actually record an event at the time of the patient's collapse. The other thing to remember is that, particularly in old age, you may see many asymptomatic arrhythmias. That's little runs, say, of an SVT or atrial fibrillation. The patient didn't record having any symptoms at all at the time. They're completely irrelevant. What you're looking for is the rhythm the patient was in at the time of the collapse. So moving on now to the neurally mediated syncopes, how do you pinpoint a cause for these? Well, the key factor is a history of the classic warning symptoms, the very specific triggers, and that relatively rapid recovery phase. And I've just put out a few of the common triggers here. For vasovagal syncope, that will always happen after prolonged standing, often in a warm, crowded room. So if I conk out just now, it was probably a vasovagal. Carotid sinus syndrome is caused by anything that causes sudden pressure on the carotid sinus. So a sudden head movement, sometimes even shaving in men, or wearing a very tight collar can induce this. The situational syncopes are very much associated with a typical event. So people that pass out when they see a needle or blood, that would be a situational syncope. Prolonged coughing, which you might see in someone with COPD, can cause them to pass out. Elderly men with enlarged prostates can pass out after straining to pass urine against an obstructed bladder. And someone very constipated straining at stool again, if they strain hard enough, may pass out. Postprandial hypertension obviously occurs after a very heavy meal. And finally, orthostatic or postural hypertension occurs after standing very quickly, immediately after standing. Address. Now, clearly we can't do a great deal about aging, but unfortunately it does make this type of syncope much more common. On the other hand, you can address volume depletion, look for dehydration. Is the patient on an excessive amount of diuretics? Have they bled from somewhere? And much more rarely, but can occur, do they have Addison's disease? And we particularly look out for this in patients with postural hypertension with no other cause. Patients may need advice about appropriate alcohol intake, and you should also look at their medication, in that there are certain drugs that can provoke the syncopes of this sort, particularly ACE inhibitors, calcium channel blockers, diuretics, and long-acting nitrates. And you should think carefully about whether these drugs could be withdrawn or even the dose reduced to try and prevent further events. So what about further assessment in the syncopal patient? Well, a 12-lead ECG, as I've explained, is mandatory in all patients, no matter how good the history for neurally mediated syncope, as you don't want to miss an underlying cardiac cause. All should have lying and standing blood pressure. This is done by asking the patient to lie down for 10 minutes, then checking their blood pressure in that position, then asking them to stand up, checking their blood pressure again at 1, 2, and 3 minutes, and asking the patient if that activity provokes their symptoms. And orthostatic hypertension is defined as a drop in systolic blood pressure excuse me, at 20 millimeters mercury or diastolic blood pressure of 10 millimeters mercury within 3 minutes of standing. In selected patients, you should go on to rather more specialised tests, but certainly not in everyone. The patient that describes blacking out after moving their head or neck or shaving with tight collar should have carotid sinus massage performed with ECG monitoring. If this provokes an asystolic episode and a blackout, a cardiac pacemaker will be curative. Tilt testing to 70 degrees for 30 minutes is the diagnostic test for vasovagal syncope, and generally it's completely unnecessary to perform that to make the diagnosis if you have a good history. But if you don't, the symptoms are atypical, the patient is having recurrent events, and you excluded a cardiac cause, it can be very helpful to pinpoint the cause. In patients with orthostatic hypertension with none of the exacerbating factors that I described, you may want to think about underlying diagnoses that might be associated with that, and these include the Parkinson's plus conditions, particularly multiple systems atrophy, and also the autonomic neuropathies that you might see in diabetes or much more rarely in amyloid. So what about assessing the patient where you have a history that would fit with seizure? I would stress very much that you must have that history before assuming a seizure. These tests don't make a diagnosis of seizure, they simply tell you what may have caused it. And the first step is to exclude a provoking cause, which is usually a metabolic one or infective. So you want to see the U's and E's, looking for hyponatremia or hypernatremia, liver function test for liver failure. You want to check for hypoglycemia and also hypo or hypercalcemia. You'd want to make a search for infection, first by fairly general investigations such as a full blood count, ESR and appropriate cultures. And if the patient has any signs of meningism, you may also need to consider a lumbar puncture, but clearly you would do a CT first to ensure there's no sign of raised intracranial pressure. The persisting confusion or drowsiness that perhaps goes on longer than the expected 12 to 24 hours. Those that have fever or ongoing headache. Those with a recent head injury or history of cancer or HIV. People that had a focal onset seizure, that is, started in one limb and then spread throughout the body. And finally, people who are at risk of bleeding, either because they're on anticoagulants or they have an underlying bleeding disorder. Should an EEG be done? Well, it certainly won't diagnose seizure unless it's done very quickly after the event, and often that's not possible. Later on, it will not tell you if the patient's had a seizure or not, and it's really only useful once the diagnosis of epilepsy has been established, and that it will help you to predict whether fits are going to recur and also whether the patient has a primary epilepsy syndrome. The witness account is absolutely essential. You need to know what happened during the event and the appearance and behaviour of the patient subsequent to the event. Again, in the UK, if we suspected someone would have a seizure, before making a diagnosis of epilepsy, we would have them seen by a neurologist or as a specialist in epilepsy, because misdiagnosing epilepsy has major implications for your patient. You're going to put them on lifelong drug therapy, which is toxic and has significant adverse side effects. You're putting them through social stigma, and you're also limiting their employment opportunities. So it's very important that a diagnosis is made by a specialist before the patient receives any anticonvulsant therapy. So don't start anticonvulsants at once. Have the patient seen, as I say, by a neurologist. We would also advise patients about driving, in that legally in the UK you must not drive for at least for 3 years after you've had a seizure. So until the diagnosis is made, it's safer to tell the patient to stop driving in the meantime. And as I say, I think they're in many ways the hardest to assess. Quite clearly, the cardiac, neurally mediated causes and seizures can cause patients just to be lightheaded rather than cause a full-blown blackout. So that's the place to start and go through a similar assessment to that which I've described. However, you have to think much more broadly because there are other causes. So a big but in here about this broader differential. You have to think about, did they simply fall? Have they got some gait abnormality that makes them more prone to falling? Could they have had a TIA or stroke? And finally, did they actually have vertigo or a spinning sensation rather than lightheadedness, raising a different range of disorders? Is their vision impaired? Do they have any evidence of cognitive impairment, be that due to delirium or dementia? Now, the reason for very specifically searching for these risk factors is that there are meta-analyses published that show that if you address these, you can prevent up to 30% of falls recurring. So a very important assessment that should be done. TIA and stroke. Well, it's important to remember that a transient ischemic attack is a focal neurological deficit that lasts less than 24 hours. So dizziness, blackouts, confusion and amnesia are not focal neurological deficits, and TIAs will not cause these. So if you don't get a clear history of a focal deficit, either of weakness, sensory loss, or visual loss, the diagnosis is not TA, and you can think again. There's blood chemistry, including glucose and lipids, and an ECG, and then obviously commencing antiplatelet agents to prevent a stroke occurring. A stroke, on the other hand, can cause loss of consciousness, particularly at its onset, but usually the diagnosis is more obvious because of a persisting neurological deficit, be that a hemiparesis, speech, or visual field defect. Would it be a space-occupying lesion or demyelination? I could talk a lot more about vertigo, but I don't think we have time just now. So to summarise, when you're assessing a patient with collapse, you very much have to adjust to their presentation. In the unconscious, it's a medical emergency unless due to head injury. Take the ABCD approach and consider neurological, metabolic and toxic causes. In people who've had a self-limiting episode of loss of consciousness, consider syncope versus seizure. A detailed history and witness account are absolutely essential, along with a 12-lead ECG, lying and standing blood pressure. And finally, those that have collapsed without losing consciousness, if they don't have any typical seizures of pre-syncope or partial seizure, broaden out the differential to falls, TIA or stroke, and vertigo. So that's all I have to say. I'd now just like to ensure that you've all been listening. I'm going to ask you a few questions, and these questions are taken from the Davidson's multiple choice website. To answer, in a patient presenting with blackout, which one of the following features is most suggestive of a seizure? A, no warning prior to blackout. B, severely bitten tongue. C, urinary incontinence. D, extreme pallor. And E, rapid recovery following the collapse. All right? No, we're going to do this properly. Oops, I'll give you the answer. Rats. Okay. Hands up, all those who got both right. Congratulations, I'm impressed. As I say, not only does it explain why that answer is correct, but the website will also go on to give you much more detail on how to assess that particular problem. This is the case for every question on the website, so I'd recommend it to you.
A big thank you from all of us, Dr. Nicki, for this wonderful insight into collapse and for demystifying collapse for us. I now request our Dean, Brigadier S.S. Anand, to kindly hand over mementos to our esteemed and honored guests. Thank you very much.
Thank you so much.